Hello, everyone, and welcome to today's episode. Shaun Brewster and Bodine Ledden with you back again. Today, we're going to continue the conversation on from our last episode where we were talking about radiculopathy, and we had more of an interview process rather than discussion, which we're going to continue this time. Where I'm going to throw some questions to Bo about the topic. Today's topic being radicular pain and all things related to this because it's such an important differentiation between the different types of nerve presentations we get, but also to be able to understand that and know what to do with it when it presents clinically. So, Bo, radicular pain today. First of all, do you want to start with by rehashing the differences between radicular pain and radiculopathy and what they mean to us?
Yeah, okay. So when we're talking about radiculopathy, so radiculopathy, interestingly, is not associated with pain. So there is a loss of sensory and or motor function. And this typically occurs with some form of impairment at the spinal nerve root. Radicular pain is associated with pain, but it's not necessarily associated, well, it's not associated with a loss of function. So it can be associated with an inflammatory component that increases the excitability or the sensitivity of that spinal nerve root. And the pain distribution may be in a dermatomal distribution that's, I guess, a neuroanatomically plausible distribution. They don't necessarily always match the specific dermatomes. In fact, it's far more normal not to match a specific dermatome that we see in our pictures in our textbook. But that's the clear differentiation is radiculopathy, usually negative signs, so loss of function, sensory and or motor, whereas radicular pain, positive signs, so there's heightened sensitivity or sensory gain.
Understood. That's good to differentiate the two. And so if we go then to some clinical application of this or examples, where do we see the source of radicular pain typically? What sort of things are going to cause that to present in a patient?
Yeah, so it's most commonly, it's going to occur at the spinal nerve root and most commonly from disc protrusions or herniations. And that is the most common form of radicular pain. Now, there may be some compression or there may not be compression. There could be the inflammatory markers. And so, for example, there might be a disc injury, an acute disc injury. There could be a facet joint injury. There could be a sprain or a strain around that area that causes inflammation and sensitization that irritates the nerve. So you get more sodium sensitive ion channels. So basically these little channels that within the nerve that are, I guess, abnormal impulse generating sites. And so sodium will rush in, generate action potentials from this sensitized area. Um, and so that's typically where it's going to happen. And so radicular pain from a spinal nerve root in origin would be different to like a peripheral mononeuropathy, where you might have just entrapment or sensitization or trauma to a peripheral nerve. For example, the common fibular nerve at the neck of the fibula, if you'd received some trauma around the neck of the fibula that caused some sensory change in the dorsum of the foot and anterior aspect of the leg, then that would be more of a peripheral mononeuropathy affecting one nerve.
Gotcha. And so the source of a radicular pain presentation is typically mechanical and or chemical at the site of the nerve root. So we can have a compression from a disc, for example. We might have a formation or some kind of occupying lesion, or we get a buildup of pro-inflammatory chemicals at the site, which become a chemical irritant, increasing the sensitivity of that nerve and giving you nerve-related pain. Is that a good summary?
Yeah, exactly.
Yeah, great. And so we do differentiate, though, then the radicular pain from a peripheral nerve-based presentation. Why do we have these two categories as opposed to just calling it nerve pain? Like, why do we have radicular pain versus peripheral related pain?
Yeah, well, it is important to differentiate the two. Often when it comes back to treatment, are you going to be focusing the treatment around that spinal segment, or are you going to focus that treatment around that peripheral site of sensitization or irritation? And when it comes back to the context of manual therapy, movement, and exercise, well, for example, you might be looking at neural sliding techniques throughout the distribution of that entire nerve, or you could be more specific to a certain location. So around the spine, you might be looking at more opening techniques, versus when you're looking at peripheral mononeuropathy, you might be targeting those sliders around that mechanical interface of where that specific nerve goes through. So it will influence the overall treatment, and even potentially could help us to understand the prognosis as well.
Okay, good. And so when somebody presents with, I'll give you a classic example, would be like a tingle, we're not talking about tingling, a pain down the arm. So they're getting a pain that travels down their arm, seems to be following the path of a particular nerve, for example. And we want to identify whether it is a peripheral compression of a nerve or whether it's a nerve root compression causing that irritation and discomfort. What sort of process would we go through? What steps would we take to identify either the source coming from the spine at the nerve root or somewhere along the path of the peripheral nerve?
Yeah, so it really does come back to a good neurological examination. So, very similar to what we spoke about in the last episode, but looking at your reflex testing, your muscle power, sensory examination, and then if there is nerve mechanosensitivity, so if they're experiencing like a dysesthesia, then your neurodynamic tests would be important. You can even look at nerve palpation around those mechanical interfaces, and even palpation of the spinal segments as well with the PA provocations or spring testing. You can then look at more, I guess, special tests for example, if you're looking at if it's more of a cervical radicular pain, things like your Sperling's test, your distraction test, it might give you a bit of an idea if it is more related to the cervical spine and provoked or relieved by a spine Sperling's or a distraction test. Versus something in the periphery like a Phelan's or reverse Phelan's test, your Tinel's signs, which, they're not the most specific or sensitive in isolation, but when we start to cluster these things together, you can get a bit better idea is that irritation coming from somewhere in the periphery, such as a carpal tunnel or a cubital tunnel or a pronator teres syndrome or a radial tunnel syndrome. You can start to get a bit better idea of where that side of entrapment is actually occurring, peripheral or central, and does that also align with their mechanism of injury? So the history is also important. The types of activities they've been doing that may cause the onset of their symptoms.
Sure, that's good to know. So if we consider a radiculopathy where someone has a loss of neurological conductivity and then as a result paresthesia, for example, is there a reason to believe that that would progress to become radicular pain? We often see a lot of neurological presentations that become progressively worse over time, and that people can catastrophize. They go, "I'm getting tingling in my fingers. If I better get this sorted because if I just leave it, I'm sure in a few months' time I won't be able to use my arm," right? And we do see examples of those kind of things progressing over time, but is that the expectation?
So sensory changes that could turn into a loss of function.
Yes.
Well, it's probably one of those things that it just requires monitoring. So, from a clinical point of view, getting some good objective measures from the start. So if it's sensory changes, mapping out those sensory changes, seeing how that's progressing over time or regressing. So using those measures to start with, documenting that, and then following up over several sessions to see if the irritability of the symptoms is changing, the distribution of the symptoms is changing, and also the longevity of symptoms. Are their symptoms sort of, I guess, less frequent? Are they lasting for a smaller duration of time? Are they able to get on with their activities of daily living or functional activities easier? So it's important to monitor these things because nerve pain can be really challenging. It can be really slow. It can be made worse quite easily as well. And so certain factors can influence the sensitivity and the irritability of nerve-related pain. So I guess will it progress to more of a loss of function? Then it just needs to be monitored. And if symptoms are regressing, it's actually getting worse, then that would potentially be indication for referral. Um, so, but would that cause potentially then a loss of motor function? Well, if it's not affecting the motor nerve, then no. Would be a simple way to put it, particularly if it is more of a mononeuropathy. But also if they're then starting to not use that area and having more learned non-use, then that can also cause changes to occur in the brain as well, in the primary motor cortex. But yeah, I think that the importance here is just to monitor their symptoms. And if there is a loss of motor function, if you're talking about a radiculopathy or even a painful radiculopathy as another category, um, if there is marked loss of function and the symptoms aren't progressing or they aren't getting better with time, then absolutely that's indication for referral.
Gotcha. Okay. And so while we know that some presentations will progressively get better over time, they will self-resolve, and sometimes the treatment or the management plan is to just monitor, check in, observe, and wait, right? Things can resolve themselves. What are potentially some of the serious or longer term outcomes of somebody who's had a longer mechanical or chemical irritation at a nerve root that isn't addressed, but just tolerated? So for someone's got pain coming down their arm or their leg, for example, and it's a nerve root source, and they can manage it, but it's still not very good. So they just tolerate, just put up with it like a lot of us will. What's the potential fallout from that?
Well, I mean, if it's manageable and they can get on with their activities of daily living and their life, I think it's just about how can we progress that little bit further. If it's I think if it's not affecting their life, then it's probably not serious. But you know, especially when there's no significant loss of function. I think that's the important thing. When there's significant loss of function, it's affecting their life and there's no progression with treatment. That's when we need to be investigating these things a little bit further. But I guess as far as sensory changes that aren't really changing, they're no worse, they're no better. It's probably not screaming alarm bells in the absence of any other red flags or any other serious signs.
So there's no threat of irreversible damage to a nerve, um, or things that could potentially become irreversible.
Well, potential. I mean, if you've got a compressive neuropathy and the longer that there's compression there, well, that could lead to demyelination and fibrotic changes within and around the nerve. And so, yeah, you can get axonal damage, and that will impair action potentials and conduction from that nerve. Um, but that's sort of when we'd be starting to see more of a loss of function. But yeah, absolutely, you can get longer term damage to a nerve if it's deprived of oxygen and blood supply, then that will lead to demyelination.
So coming back to your original point about monitoring for progression and regression in signs and symptoms and clinical features, if things are getting better, great. If things aren't getting better, do something about it
Yeah.
because it can lead to some of those more structural changes in the nervous system that can be very difficult to resolve. But not every neurological presentation will end that way. I think, is that the key takeaway?
Yeah, that's right. And I think the important thing is movement, just getting people moving. And whether, if they're really irritable with radicular pain or even a peripheral mononeuropathy, is to start to use manual therapy to decrease symptoms, use neural mobilization to decrease some some guarding and pain and getting them comfortable with larger amplitude movements, you can then start to get a little bit more specific with those neural mobilizations, to target those specific mechanical interfaces and improve their comfort. But what that's really aiming to do is improve blood flow and oxygen to the nerve, decrease some of that protective guarding of muscles, and allowing that nerve to move through its interface a lot more effectively. And then if we can start to get people to perform normal exercise, then the benefits of that not only on the neuromusculoskeletal system, but just overall health, that can also help with decreasing nerve related pain and symptoms.
Okay, great. And so when we start to consider all these different types of neural presentations and things, there's some long held and often cited treatment approaches that people will say this is what you do for when you get a nerve compression, to say from a disc, for example. The classic one that always comes to mind for me would be like the McKenzie extensions for a lumbar spine, things like that. So how how useful are those approaches that are here's the technique, here's the modality, here's the approach you use for a disc bulge that causes nerve compression or nerve related pain? Like how useful are those approaches now? Should we be looking a little broader? Are there different ideas? Where do we go now with that clinically?
Yeah, they're good for the right person in the same way that flexion-based exercises are good for the right person. And so, do one or the other, depending on the patient in front of you and how they respond. So, some people will be their symptom. It'll come back to an assessment. Are their symptoms actually worse with flexion of the spine? Is it worse with extension of the spine? It could depend on what's going on. And starting to, in the early stages, you might say, all right, well, if flexion actually increases your leg pain, so when we're looking at spine related leg pain or radicular pain, let's move into some extension for a while until this starts to settle down, because we know that with radicular pain, it's associated with inflammation primarily, and so that's obviously going to be highly sensitive. And so get them to move in an environment that's comfortable, that we can promote some blood flow, some oxygen, and dispersion of these inflammatory mediators within and around the nerve in the short term. And then as symptoms start to decrease, let's start to gradually expose them to those other movements of moving into flexion. And the same would be if it was extension was more provocative. You might start them in the short term going into more flexion based movements, and then start to move them into some extension to get them back to their normal movements or normal functional activities. And so I guess as the nervous system sensitivity settles, then we've got more room for activities. We've got more opportunity to start to explore different movements. We can start to explore more end range movements with neural mobilization, whether that be going from neural sliding techniques to more neural tensioners. And start to challenge the system a little bit more. So we do get these adaptive responses, but less fear of movement and less guarding and mechanosensitivity that goes with that.
Yeah, absolutely. And I think you touched on a key point there, that fear of movement. There's so much that comes with neurological related presentations that is fear inducing. It's often not brought on by an incident, a mechanical incident like a sprained ankle. I understand why my ankle hurts now because I rolled over that rock and now it's something tore or is damaged. I understand it. Neurological presentations can be very fear inducing because we don't always know what happened. There's often no moment in time. It can be insidious in the way it comes on sometimes. And so I think that concept of addressing the patient's psychology and allaying their fears and helping them understand the reality of the situation and the opportunities for improvement, I think is really important. Absolutely, we are dealing with anatomy, so there is structural and functional components to the rehabilitation process, but there's also a person attached to that anatomy. And what goes on in their head and the stories they create for themselves, the meaning behind their presentation can be who knows what until we dive into it. And so addressing that is important too. Do you want to talk a little bit about that from your perspective?
Yeah, it's so important just to understand patients' perception and, if they're really fearful of movement, well, obviously that's going to impair them from moving into those positions again because there is a previous experience that's associated with pain or something that caused them harm. Then there's the expectation of this potentially happening again or that experience of pain coming on again. And so the response from that will be a learned response to say, well, don't go into that position because it's potentially dangerous. And so obviously the more that they or the stronger that they believe that, the more that they'll be avoidant of those movements. And I guess educating our patients that about movement and that yeah, certain movements can be sensitive, but your brain is in a bit of this overprotection mode at the moment. And so, what we need to do is start to calm that system down, get you a little bit more comfortable with movement. This will be a very sensitive period for the next 2 weeks, 4 weeks, 6 weeks, however long. But it's important to note that it is that your nervous system is really sensitive, that you're not doing any further damage. But we do need to start to get you to move and get you a little bit more comfortable in these positions. And I guess de-threatening the situation by saying, look, we've done a thorough neurological examination and there's no serious signs here. There's no serious red flags that I'm really concerned about. What we will do is we'll monitor your symptoms over the next several weeks nice and closely. And I want you just to let me know if anything abnormal starts to come up or anything that you're really unsure about, then please let me know. Um, but then starting to challenge people to move into a little bit more of these larger ranges so we can challenge their beliefs about movement and get them comfortable with moving again. Otherwise, it can potentially lead to some significant downstream consequences in the long term and potentially persistent pain. So yeah, really educating our patients is super important. And sometimes they might have a get an imaging report and there's I've basically the my discs exploded and it might be like a disc sequestration or an extrusion where the nucleus pulposus moves through the annulus fibrosus and it can be incredibly painful because there will be a significant inflammatory response. There may not be any loss of function, but because the nucleus pulposus is sort of foreign matter, it could also be an autoimmune response that goes with that. And so it can be severe radicular pain. And as far as prognosis goes, we know that most people will get better within 3 months. And in fact, the prognostic outcomes of the, protrusion, extrusion and a sequestration is better than sort of more minor disc bulges or protrusions. And so educating our patients about that yeah, it will be really sensitive, but over time this should start to get better, and we're expecting some really good changes in the next few months. But just start to get a bit more comfortable with that movement, I think is really important.
Yeah, that's good. And it's interesting to know the sort of spontaneous healing rates and how they are quite high. I've got a colleague of mine who he triages the list for a neurosurgeon who does primarily backs and spines and stuff. And he had recently had to go through the list of all the people who had been waiting for many months, in some cases years, to see this neurosurgeon, and called up all these patients, and there was hundreds on this list, and over half of them said, "Oh no, I don't need the surgery anymore. It just kind of got better." So their treatment was just the waiting list. They just had to wait, and while it was uncomfortable, knowing that there was something to come, so that they had a positive kind of view for the future. And I think that's a mindset thing too, and time. Those two things, a positive mindset and time, it resolved and they no longer needed the surgery. And so, while it seems like a failing of our healthcare system, for those patients at least, that was a surgery they didn't need to have. And all the negative things that potentially come with surgery didn't have to happen. So, that's a really good thing. So, Bo, there's a lot going on in the nervous system. It's a complex system, and you've just reeled off very eloquently a lot of different things to consider as far as assessment, pathology as a whole, treatment and management, rehabilitation from a physical, psychological aspect. If somebody wanted to learn more about this stuff, where might they go?
It's got to be the ACE neuro assessment and treatment course.
Do ACE run one of those courses, do they?
Yeah. Yeah, and look, do you know what? It really is a fundamental skill set. And even, it is taught in some undergraduate programs, not all. I think there's always gaps in that training, and often when you do learn it in an undergraduate program, you don't have the context to apply it. And so after you've been out in industry for a while and seeing a lot of these presentations and how they behave, um, it really is important to go back and revise this stuff or review it or learn it if you haven't already, because um, it is a complex system, and understanding, I guess, the pathoetiology of the primary drivers and the contributors for nerve-related pain, radiculopathy, painful radiculopathy. It really is important. And I think we can help so many more people, and we can help so many people avoid unnecessary surgery, unnecessary injections, and the long-term use of opioid drugs.
Percent. And you're absolutely right. Understanding more about the nervous system, how it works, and also how it breaks, as in how it presents clinically, and then what we can do about it. Speaking personally, and I think you probably agree, the more I've learned about the nervous system and how to interact with it and how to work with it, the more it's helped me understand pain in general, because obviously the pain and the nervous system are intrinsically linked, but also every other modality that we use in clinical practice as a manual therapist, everything, all of the assessment, all of the treatment approaches, the more you understand about the nervous system, the better you understand those things and the more effective you get at using those things. And I think that's been a great realization for me in recent years. Like the deeper we've dived into this, the better I've got at being able to do all of those other things that we do. And so it's such a foundational block, I think, in our knowledge that we can't overlook.
Yeah, and the nervous system, it can be scary and intimidating if you don't know much about it. But when you do start to understand it a little bit better, you can work with it better.
Mm.
You know how things will potentially, behave if you do too much or if you do too little, and where those thresholds sit, and how we can interact with our patients a little bit better, and how that might influence our treatment outcomes. It's just such an important component of everything we do. And I think manual therapy can be a fantastic way to modulate pain and even modulate symptoms of radicular pain. And that can then be co-managed with exercise and other therapies as well. So, I think it really ties things together nicely with the use of manual therapy.
Perfect. I think that's a great place to leave it. So thank you both. Thank you for sharing your knowledge on this topic, on this session, and our last episode as well. Those two concepts together, I think, are a really key kind of sandwich of ideas that I think everybody can benefit from. So if you haven't listened to the previous episode, go back and check it out. I think it'll tie it together nicely for everyone. So thank you both. Thank you everyone for tuning in, and we'll see you on the next one.
Cheers.